Thank you so much, and thanks for having me today. I'm going to talk a little bit more of a high level when I talk about knee replacement, and part of that is because, frankly, our literature and our evidence is not that great. So we use opioids for total knee arthroplasty, and if you ask orthopedic surgeons why, they would say because we've always used them, and that would really be the honest answer that they would give you. Not because we've ever had any great evidence to support what we're doing. These are my disclosures. I don't think any of them are particularly pertinent today. I did ask leadership of the two organizations that I work with routinely, the American Academy of Orthopedic Surgeons, the American Association of Hip and Knee Surgeons, to look through my slides and see if anybody had additional recommendations, so I appreciate their support. So total knee replacement, we do about 700,000 of these a year, so for orthopedics, certainly it's our number one thing that we do on the inpatient setting. It's continued to grow. When I was a resident doing total knee replacements, patients stayed in the hospital for 10 days. We didn't prescribe them on any opioids to leave the hospital because they were in the hospital, and every bit of pain medication they receive while they're in the hospital. Well, if you have a total knee replacement now at Dartmouth, your average length of stay is 1.2 days. So how do we get from 10 days to 1.2 days? Part of it is by improving the techniques that we use for pain control. And one of the ways that we improve those techniques, unfortunately, was through the use of opioids. The outcome for total knee replacement over anything else that we do for somebody that has grade 3 or grade 4 osteoarthritis is 2 times anything else. So we talk about conservative treatment for knee osteoarthritis and knee replacement, but knee replacements, the outcomes are really quite good, so it's hard to argue against them. And overall, patient satisfaction is good. It's not perfect, but it's pretty good. The pain response when you have a total knee replacement is multifactorial. There's an acute pain response, as we have with any surgical procedure. Rick Barth, who writes a lot of the surgical literature on opioid use at Dartmouth, general surgery, their need for pain medications is different than orthopedics. We have the acute inflammatory event. They have one as well. We have a nociceptive event as well. But we also have an ischemic event when we do total knee replacements. Most total knee replacements done in the United States, over 95% are done with a tourniquet. So for anywhere from an hour to 2 hours, there's a tight constricting band around the upper thigh. And so initially after surgery, and really it can last for up to 45 or 60 days after surgery, there's an ischemic event that people recover from, and that does add to the pain associated with knee replacement. And then the other thing that we have with knee replacement is the average age of a knee replacement patient in the United States is about 65. So we have a whole history of patients living a life. And many times when they're living that life with knee osteoarthritis, they've had lots of opioid pain medication exposure a long time before they've seen us. And I'll talk about that a little bit more in a second. So for us, this is really an acute on chronic type of pain response as well. We're managing multiple comorbidities as everybody else is associated with this, but there are a lot of things that we found over the years to be really important for this. And then the other thing that's critically important for us is this need for relatively early and intense physical therapy after a knee replacement, probably more so than any other orthopedic procedure we do. We know that the ability to get somebody moving after a knee replacement has a significant impact on outcome. But like with everything else, pain is entirely subjective. So if we look at this slide of a soccer match where a soccer player's flopping, they look like they're in agony when we know really nothing's wrong with them. They're just hoping that the guy gets a yellow card for some perceived grievance against them. Whereas you look at a football player or a hockey player, now these guys look like they should be in agony, but they go out and play the next down. And when we're looking at our knee replacement patients, it's kind of the same. We have people who are in agony after they have a knee replacement. We have people that cruise through and never take a bit of pain medication. So there's something that we need to understand more about our patients and about the phenotypes of these patients and the subjective nature of pain that will help guide us for the future. And we haven't been so good at doing that to this point. So this is a study we did, and it's actually one of the first studies looking at opioids in orthopedics. And I show this slide for a couple reasons. One is because there's a difference between total knee replacement and many other things that we do in orthopedics. So total knee replacement does appear to hurt more. We do use more opioids, and patients fill more pain prescriptions. We also found, however, that overall patients are pretty satisfied with how we've treated the pain. The problem we found with our studies, if you looked at the number of opioids we prescribed and the number of opioids the patients actually used, every 6 months in New Hampshire and Vermont, we were putting about 45,000 5-milligram equivalents of Percocet somewhere out there. Now, interestingly for us, in our arthroplasty program, since 2012, we've actually instructed our patients on appropriate opioid disposal, and 40% of our patients in that study said that they disposed of them properly. So we're perhaps a little bit better than some other places, and that we've really been focusing on it. But that still left 60% of patients not either saying it was in the cabinet or not sure where it was. I know it's beyond the purview of the framework that you're developing, but where patients start in this phenotype concept is critically important for us. A large percentage of our patients come to us already on opioids. In my practice, non-tramadol opioids is 38%. So 38% of the patients I see are being treated with opioids for knee osteoarthritis. In fact, I would argue that primary care physicians in New England have a pathologic fear of using nonsteroidal anti-inflammatory medications in their patients, and it's largely driven by cardiac risk assessment. So we need to have some better concept of the risks and benefits of the medications that we have, because everything has risks and everything has benefits. And as a surgeon, I would certainly argue that the downsides of opioids is far worse than perhaps the downsides of nonsteroidal anti-inflammatory medications. Why is it important where we start? Because we know that if we look at what happens at the end, that it's really apples and oranges. We know that in our patients, those that have used opioids for greater than 1 month prior to a total knee replacement are more likely to use opioids far longer after a total knee replacement. Now, we're not zero on the opioid naive patients, but we're also nowhere near the same magnitude of those that use opioids. We know that there are a whole host of other factors that are really important in the patients we deal with as well. We know that patients that have low activation scores, patients that have no resiliency, patients that have high anxiety, all of those types of patients are going to do more poorly for a longer period of time after surgery and are going to use opiates for a longer period of time. So all of those factors play into it for us and the patients that we're looking at. So I don't want to discount, though, where we start, because it's critically important to what we do after that. There aren't really any guidelines out there looking at the use of opioids for total knee replacement, or really most other orthopedic procedures as well. This is from the Surgical Management of Osteoarthritis, the knee guideline that we did at the American Academy of Orthopedic Surgeons. And there's some things that peripherally relate to the opioid use that I'll highlight. One is the periarticular anesthetics, so types of blocks that we do around joints can work really, really well. Anecdotally, I will tell you that in the aughts, so after between 2000 and 2010, we implanted a large number of doing knee replacements, a large number of implantable continuous periarticular blockade type systems. They worked really, really well, but insurance companies said that they were more expensive than opioids and provided the same results. So that was in a situation where we had something that we were using that worked really, really well, minimized the use of opioids, but opioids was cheaper, so it lost out. So there's some things that we've done in the past that we may want to revisit in the future as we look forward. The whole concept of periarticular nerve blockade in general is one that has been shown to be effective and decrease the use of opioids. Although there's 2 really good randomized trials that show the use of tourniquets increase the number of opioids that are used in the perioperative and even long-term for patients undergoing total knee replacement. Still 95% of orthopedic surgeons in the United States use opioids. The reason is there's a perceived risk of not using a tourniquet, and that is when we're doing a total knee replacement, we put this stuff in called bone cement that we have to interdigitate into bone. If there's bleeding and there's pressure coming out of the bone, we worry that the interdigitation of that cement won't be as good. So we need some longer-term studies to show that the benefits of not using a tourniquet for opioids or outweigh the potential risk for failure at 5 years, because that would recreate a different problem. And lastly, there's not great literature to really tell us what type of anesthesia is really best, at least for when we're looking at things like opioid consumption after total knee replacement. And for almost all of these studies, it's only been short-term outcomes. So these are 30-day outcomes that we're looking at, and it's probably meaningless really for what we're talking about and what we're trying to look for the future. When I talk about total knee outcomes, this is the framework that I use. I think it mimics a lot of the same framework you had in your in the framework that you sent to us, the preliminary framework. These are the types of things that we look at, and I have where we put opioids in the bottom of that, and I think it matches well with what you're looking at as well. So I do think your framework is, from our perspective, looks very similar to what we would propose. This is the types of evidence that we have right now for total knee replacement and opioids, and I'm going to start on the right with the perioperative pain management. There's a relatively high number of randomized and sometimes controlled trials looking at the types of anesthetics that are used and their effect on short-term opioid use. The problem with most of those trials, there are over 50 of them with 50 different types of anesthetic choices described. There's very little standardization in the literature about what people are doing. We all use some form of multimodal anesthesia for our patients, or analgesia for patients undergoing total knee replacement, but the definition of multimodal is variable. And so it's hard to know, and none of the trials are big enough to really make any huge inferences from. So lack of standardized protocols is huge, and again, mostly they only look at short-term outcomes. There's a paucity of prospective randomized trials that look at post-acute opioid use. So most of the data that exists right now are retrospective database studies, which make it really challenging to know what's really happening. Sometimes we'll get a single institutional database, but again, that can be really, really challenging. And we see no dose response or no dose and length of time for the opioids that are used. So to get to the specific questions that we were asked, could the draft framework be used to develop a clinical practice guideline for opioid use for total knee arthroplasty? What improvements could we suggest? I felt that the draft framework was best applied to ideal total knee candidates. So those patients that have good mental health, so they're cherry picking, those patients who we expect to do well, a guideline will really, really appeal to them. People that are opioid naive, and people that have strong postoperative support. So Dr. Chow, I know, asked one of the previous candidates about the work we do, the Department of Surgery does at Dartmouth, looking at prescribed opioid prescriptions based on inpatient. You should understand, for total knee replacement at our institution with the 1.4 length of stay, 72% of our patients don't take any opioids while they're in the hospital because they have a block that's working. So I can't predict what I'm going to prescribe tomorrow based on what they use today because they're using nothing today, and I know they're going to use something tomorrow. We also know, based on a large database study, that the worst pain that a patient has with total knee replacement, if they have surgery at 7:30 Monday morning, the worst pain they're going to have, and this is over 60,000 patients, is going to be at Friday afternoon at 2 o'clock. So Friday afternoon at 2 o'clock, they're not in the hospital, and hopefully they're not really bothering us or contacting us, but we know that that's the case. So that's what makes some of this difficult, to be extremely prescriptive about how we do that. And we also know that it really depends on how much postoperative support that a patient has. We know, for example, that if a patient goes to a skilled nursing facility or acute rehab unit, their use of postoperative opioids is significantly higher than if they go home. If they go home and have strong family support, we also know that their use of opioids is much less. There's a lot of things that factor into it. We also know that hospitals and systems that have mature interdisciplinary teams do really well. We have a really active pain service, and we think that helps us quite a bit, but we know that most organizations don't have that. And in fact, if we look across the nation at all patients having total knee replacement, more than 50% of them are even having them done at a location that doesn't have strong interdisciplinary teams, or the patient's poorly optimized patient for surgery to begin with. So those factors really play into all of this. Could the draft framework be used to develop, or the same question, but what improvements would we suggest? In our patients, much like probably all the other patients that we've talked about, I think that the one thing that I saw lacking in the framework was there wasn't enough consideration of socioeconomic and educational factors. Those factors significantly in our studies looking at opioid use. Recognition of process factors that significantly affect intermediate long-term outcomes. So site of service, as many of you are aware, there's a big emphasis right now on putting total knee arthroplasty into the outpatient setting. So for patients that go home on the same day, what do we do for those patients? Those are very different patients than patients that stay 2 days or 3 days in the hospital. So how do we address that? How do we look at our anesthesia and perioperative pain interventions? Again, if the procedure is being done in an outpatient surgery center, it's very different than if it's being done at our institution. And I also just thought, for us, one of the things that was missing in all of this in looking at your framework was the concept of reoperations. For us, that's a huge issue. We know that there's a subset of patients who are opioid seekers, and one of the ways they get more opioids is by continuing to have pain and finding a doctor that will reoperate on them. I don't know what the percentage of those patients are, but we suspect that percentage of patients that, by our patient-reported outcomes, are doing poorly at 1 year and 2 years after total knee replacement. We suspect that approximately 5% of those patients are chronic opioid users, and that's one of the mechanisms they use. I think it's relatively crazy to have a revision knee replacement because you want more opioids, but it probably does work for what they're trying to accomplish. What evidence would be necessary to make the links a framework? The thing that we really lack are big multi-center studies, and they have to be prospective. Why do I say that they need to be prospective? Because when we look at our own data and we try to figure out 1 year out from surgery how many of our patients are taking opioids because of the procedure that we had, it's really difficult. What we found, and we've done a follow-up study to the one that I showed you earlier, is when we call patients and they're still on opioids at 1 year, many of them are on opioids because now it's their right shoulder that's hurting. And the same doctor that was giving them opioids for their knee osteoarthritis is now giving them opioids for their rotator cuff. But if you look at a big administrative database, that's just going to show up on somebody that's still on opioids. And if you could make the assumption that it could have been related to the knee replacement. So we need to have better prospective studies, and it has to be across multiple institutions. Many of us have opioid utilization and dosing strategies. I'm happy to report on them. I'll tell you that based on our study, we started doing all the dosing utilization strategies, and we are now finishing up our second study on this, looking, did we have an impact? We certainly had an impact. There are certainly less prescription drugs on the New Hampshire and Vermont market based on what we've done. But what we found is the ratios are exactly the same. So if I cut the number of opioids that I prescribed in half, the ratio of unused opioids stayed the same. So patients are able to meet whatever level we ask them to meet. And so there's an educational component of this that I think is critically important as well. And then we need to have effective risk adjustment or phenotype adjustment based on the patients that we're operating on. How might the evidence be generated? It's, if we're going to wait for high quality level 1 research, this typical kind of research that we put in a clinical practice guideline, or we'd like to put in a clinical practice guideline. It's going to take at a minimum 3 to 5 years from today to get any meaningful data that would be helpful to answer these questions. I think for something like opioid utilization, which is a national issue, I think quality improvement strategies about we're doing all of these things and we're moving the bar in the right direction is something to consider. I can tell you in orthopedics, you can't get these types of studies published, and they're hard to get published anywhere because there's no internal validity in these studies, but they do move the bar in the right direction. Volume of patients in orthopedics and total knee replacements not really an issue. At 700,000 a year, we can enroll, although usually the problem we have whenever we do any type of enrollment based on pain medication control, it's harder to get patients to enroll. They're really concerned that they're going to be in pain. We need the studies that last long enough to get those intermediate and long-term outcomes, and of course, all these types of studies are expensive. How can we conduct these studies? I think that utilize existing longitudinal registries would be extremely helpful. We do have some in orthopedics. We do have some for total knee replacement. We have a history of nesting small RCTs in the big registries, then trying to make big inferences from that. We've been relatively successful at doing that. We could also focus on vertically integrated health systems like Kaiser, which has a huge knee arthroplasty registry. They collect all the data right now. They have a lot of this information. Intermountain's another one that comes to mind that could do that. Or work within existing randomized control trials or clinical trial networks. We have multiple national trials going on right now for knee replacement. The biggest is the PEPPER study. It's a 25,000 enrollment study. We're 8,000 patients into it. We still have 17,000 to enroll. It wouldn't be that hard to add a little bit to what we're already doing with the study. How can we practically disseminate and get the information out better? The first is education. And as I talked about, educating patients is critically important. Whenever we set goals for patients, they seem to want to meet them. I think that's very similar to what Dr. Bateman found in some of the work that he did through his shared decision making. But there's two other parts of education that are really important. For us, there's the education of everybody that's involved with the care of that patient. And this is what I describe as the George effect. 4 years ago at Dartmouth, we were trying to decrease our length of stay for total knee replacement. So in all of our preoperative education, everybody was giving the same message to patients that we thought they'd stay in the hospital 2 nights, 2 nights, 2 nights. We implemented our program, and 4 months into it, everybody was still saying 3 nights. Well, it turns out that George, really nice guy who works in administration, when every patient was checking in and they'd say, well, I'm planning on staying 2 nights, he'd go, no, most patients stay 3 nights. So all it took was one person to really totally destroy everything that we're doing. And when it comes to opioid education, it's very similar. Physical therapists will tell every one of our patients, you need to take 2 Percocet before you come to your therapy appointment. That's not based on any evidence. That's just what they tell them. So our patients believe things like this. And so education is not just for patients. It's not just for physicians. It's for everybody involved with care. And I think, obviously, a lot of organizations are trying to weave this into licensure and certification. It has to be scalable. It has to be applicable. And I think also for orthopedics, where we have a lot of other programs going on with Medicare, integrating this type of thing into MIPS would be awesome for us. It's something that we could achieve, and it's something that would improve the outcome for patients. Are there prescribing nuances for opioids that should be captured in a clinical setting? In a clinical practice guideline, I think much like everybody else has said, that's very much the case. We need to allow for personalized care. Whenever I made a clinical practice guideline with the American Academy of Orthopedic Surgeons, I always argue that we're shooting at the 80%. There's only going to be 20% of patients it doesn't apply to. As long as you're shooting for the 80%, we should be good. We have to think about site of service. We have to think about the multi- and interdisciplinary nature of care and the fact that in orthopedics that doesn't exist everywhere, and then the paucity of behavioral health services that could really help the outcomes for many of our patients. So lastly, this is just a conclusion slide looking at, I think, at all the opioid evidence that we need in total knee replacement. I think it's myriad. If I could focus on one of those areas, it would be a short randomized control trial to show that nonsteroidal anti-inflammatory medications in a short-term usage do not increase cardiac risk, because I think that would be one of the really extremely helpful things that we could focus on. Thank you.